pressure to the abdomen. They also stimulated the victim by means such as rectal fumigation with tobacco smoke, which thank God is not a used method anymore. So that was kind of where it all initially started with over in Amsterdam. Following that, in 1891, Dr. Frederick Mass performed the first documented chest compressions in humans. And then by 1903, Dr. George Cryle, I think you pronounce it, reported the first successful kind of human resuscitation. It's kind of dates along a few hundred years back, and it's quite a bit different to obviously what we use today. So what is cardiopulmonary arrest? So cardiopulmonary arrest, also known as CPA, is defined as a failure of effective circulation and ventilation. So it's kind of split into two different categories. So there's respiratory arrest and cardiac arrest. So respiratory arrest, this is the sort of the complete stopping essentially of respiratory movement. And with the absence of this obviously then proceeds to lead on to cardiac arrest. Cardiac arrest is defined as the sudden and often unexpected stoppage of effective heart action. You might find if a patient's in cardiac arrest that there might be still some electrical activity in the myocardium, but it's not effective at pumping blood around the body and delivering effective perfusion. So that point is then classed as an arrest. Just a couple of other kind of definitions and terminology you might hear of with cardiopulmonary arrest. So agonal gasps, these are not to be mistaken for true kind of respiration and breaths. They are a brainstem reflex, and often with these you kind of do see jerking movements. The mouth is often wide open and movement can be vigorous enough to move the patient's body, and it's definitely not effective ventilation at all. Apnea, this is also the absence of respiratory movement, but is quite self-limiting and temporary. So you might find this sometimes with like anaesthetics and things with certain drugs. So for example, fentanyl can cause apnea, but generally it is temporary and the patient will start breathing again. CPA is quite an uncommon occurrence, with less than 1% reported in veterinary hospitals. So it is kind of, obviously depending where you are, it's not something that's seen particularly often. So then going on to kind of causes of CPA, this can come from a kind of a number of different aspects. So it could be kind of, like I said before, drug reactions or a drug overdose. It could be due to a disease process, whether that's neurological or metabolical, as a result of a toxicity. Prevention of adequate respiration. So like I said before, cardiac arrest occurs when the heart and the brain lack oxygen. So it's generally secondary to the respiratory arrest. An inadequate amount of oxygenated blood reaching the heart. So this could be due to hypertension, hemorrhage, or anemia, any of those kind of conditions. Extreme hypo or hyperthermia, and any unexplained kind of anaesthetic depth change can also be a cause. So signs to look for if you think a patient's gone into CPA. If you are suspected, this needs to be kind of a rapid assessment of the patient, and should take about 10 to 15 seconds, if not less. Kind of things that you are looking for if you're suspicious of a patient being in CPA, sorry, is a change in the patient's mentation. So have they suddenly gone from kind of being a bouncy bright dog to then suddenly being collapsed and non-responsive? Syncope, bradycardia, tachycardia, or any kind of ECG arrhythmias that you might notice as a sudden change. If there's no heart sounds at all, so obviously if you do notice a change, you go to listen, there's no sound to be audible. Bradypnea, dyspnea, or the agonal gasping, like we've just mentioned. Any hypercapnia, hypoxemia, hypertension, if there's no palpable pulses on the patient, any dull cyanotic or grey mucous membranes, and a prolonged capillary refill time. So anything at that you're looking at over 2 seconds would be classed as prolonged. If their pupils become kind of central and dilated and there's no cranial nerve reflexes, so this would be kind of a lack of reaction to any sort of stimuli for the patient. So obviously if you do notice the patient has gone into CPA, at that point you would want to start resuscitation. So CPR is obviously the emergency procedure we use when a patient does enter cardiopulmonary arrest. We do associate a lot with CPR, what we call return of spontaneous circulation. So this is kind of defined as clinical signs of restored effective circulation within a patient if they have gone into CPA. With that, you're looking at effective circulation lasting over 30 seconds. So that could be palpable pulses coming back for over 30 seconds, a systolic blood pressure measurement over about 60, and a marked increase in EtCO2 with the resumption of a heartbeat as well. Or with that, you could just notice some kind of spontaneous breathing returning. Over the kind of last 30 years, the rates of ROSC and survival to hospital discharge and dogs and cats undergoing CPR has varied substantially. Most recent studies that have been kind of looked into ROSC rates in dogs and cats show that it does reach up to about 60 to 71% of patients achieving ROSC. However, the rates for the survival then to hospital discharge are still really low, with only up to 6% of dogs and less than 20% of cats going on to survive to discharge. So it's still quite low numbers, even despite kind of all the advances in CPR and things. Several factors have been identified that do associate with those patient survival rates. So that includes if the patient's under general anaesthesia at the time of CPA, so obviously they are being monitored and it is kind of picked up a lot quicker than normal circumstances. If the CPA was witnessed, so are they being closely monitored in an ICU? Did you just happen to have kind of walk past at the right time and see them kind of go into CPA, and also as well a shorter time to initiate of CPR, so the kind of quicker we can start CPR, the patient survival rates will be. CPR kind of, we do see a lot of terminology kind of split into what we call basic life support versus advanced life support. So basic life support, this is defined as the kind of administration of external chest compressions and intermittent positive pressure ventilation, so IPPV, so breathing for your patient essentially, with the intention of this to support the cardiorespiratory system in animals that are both pulseless and apneic. The basic life support can be performed both clinically and a non-clinical environment setting by, obviously it needs to be by a trained individual. So it is something you could carry out, obviously a owner could carry it out at home, obviously with them being talked through how to perform chest compressions and ventilation and things like that. Advanced life support this is defined as kind of the use of monitoring tools alongside the basic life support. So this could be an ECG, a capnograph to help kind of guide the cardiovascular support measures. It could be electrical defibrillation if this is indicated and kind of where available. Gaining vascular access and the administration of drugs and other kind of therapies to help with CPR. Unlike with basic life support, obviously advanced life support can only be performed in the clinical setting, just due to the techniques and equipment that are kind of needed and used for that. So we often find that obviously the advanced life support is something that we carry out in veterinary practice, but the basic life support is something that we can do in practice and owners can do where required, kind of out of a clinical environment. So when assessing a patient, obviously we kind of all know the ABC method, but we also do now kind of flip this with the CAB method. So this was kind of all assessed with the Recover initiative. So the Recover team, they are a established group of over 100 veterinary specialists, and it was established in 2010. Their goal was to kind of evaluate evidence-based medicine and form a consensus guidelines for CPR in both canine and feline patients. They have provided kind of a use of guidelines, which they first published in 2012. When they were first available to view, and they were considered open access and are available to all veterinary professionals. They have since been updated. They actually got updated last year, so they've kind of updated a few of the guidelines, which I will kind of go on to say further along in the PowerPoint. With this Recover initiative, so they updated the ABCs to CAB, because they found that there were no studies in human or veterinary medicine that directly looked at whether chest compressions or intubation/ventilation should be initiated first. But what we do know is that chest compressions are obviously essential and necessary for blood flow, and it is kind of stressed with their guidelines that any delay of initiation or prolonged pauses of chest compressions does reduce the likelihood of the ROSC returning. With chest compressions, kind of our main goals with them are to restore cardiac and pulmonary tissue circulation, to deliver ventilation, to oxygenate tissues, obviously where the heart isn't able to, and to restore the organ function. Chest compressions can be started immediately, as obviously the process of intubation and providing breath is longer and can be more time consuming than chest compressions, and the intubation process can be done alongside chest compressions. It is also important to remember as well, if you are the first one on scene or the only one on scene, it's more beneficial for you to start those chest compressions than it would be to kind of go straight for breaths. It has been found by research that it is actually more detrimental to delay starting chest compressions on a CPA patient, on a patient that's is in CPA than an animal that's not in CPA. So obviously, if you kind of start doing it and it ends up being the patient kind of gets the return of spontaneous circulation back straight away, obviously it's more beneficial than kind of delaying it, questioning whether they are in CPA or not, and not getting a successful outcome. It is important with your chest compressions that obviously the technique is essential. I kind of do go on to the different techniques and ways of doing chest compressions next, but it is really essential the technique is right, because even with high quality compressions, they only produce about 25 to 30% of normal cardiac output. So it's really important we kind of get the technique right. So yeah, different types of compressions. So obviously this will all vary dependent on the size, breed, and things like that of your patient. They all require different kind of technique methods. So your small animals, this is your cats, small dogs, guinea pigs, rabbits, your kind of small furries. So these require compressions using a thumb and 2 fingers. Your round-chested, kind of medium to large breed, so that's kind of your Labradors, your Spaniels, things like that. These are generally required to be in right lateral, with compression over the widest part of the chest. One easy way to kind of remember where you need to go is if the patient is lying on the side, if you bend their forelimb back where their elbow kind of meets the chest, that's kind of the compression point that you're looking for. Your barrel-chested breeds, so these require to be in dorsal recumbency just because of the shape of their chest. And your keel-chested medium-large breeds, so kind of your sighthound kind of breeds. These chest compressions are done directly over the heart, again, in right lateral recumbency. So I've got some little videos to show you. So first up, small animals. So these are your ones that require chest compressions using a thumb and 2 fingers. Obviously, my patient on the video is not a smallie, but it was the only one I had available, unfortunately. Next up, I've kind of done similar videos for this, just kind of so you can get the gist of what we're looking for. So for your round-chested, medium to large dogs, compression over the widest part of the chest, and your keel-chested, done directly over the heart. It is important kind of with compressions, you're looking at doing about 100 to 120 compressions per minute. So this is just another one of your barrel-chested dogs. Between each compression, you need to allow kind of full recoil of the chest. And in terms of chest compression depth, sorry, obviously it was hard to demonstrate on the cuddly toy, but you kind of, with the patients in lateral recumbency, you're kind of looking at delivering a compression about 1/3 to 1/2 of the width of the patient's chest. And these patients in dorsal, you're looking at a depth of about 1/4 of the anterior postural diameter of the chest at the compression point. You can kind of get the gist of what are the kind of how you need to be with your hands and things from the video, but you basically need to have one hand over the other, kind of with the heel of your hand over the appropriate compression part, depending on obviously the size of your patient. You should have your elbows locked and you kind of bending from the waist in order to kind of get that compression power and force from your core rather than your arms. You should, where you can, perform compressions by standing behind the patient and be above the level of the patient. If you kind of, I'll go back so you can kind of see a picture. If you are behind the patient like this, if the patient then kind of slides backwards from the force of the compressions, they're obviously then kind of being stopped by yourself. They can't be kind of slipping, sliding everywhere while you're trying to do compressions. Obviously, it can get really tiring when you're doing those compressions. They've done quite a lot of human studies that do show rescuer fatigue kind of kicks in when you're about between 1 and 3 minutes into doing compressions. And obviously, after that point, if you're getting fatigued, this does then result in poorer quality compressions. So it's usually recommended that you do kind of 2-minute cycles of compressions, kind of team up with someone else and swap after 2 minutes of each doing compressions. This between kind of swapping out with someone else, it's essentially factored as a basic life support cycle, which is a 2-minute cycle where you do 2 minutes of compressions, and before you rotate out with your person that's taking over your compressions, the patient should be rapidly assessed kind of by a vet to be assessed for any of the return of spontaneous circulation before starting the next 2-minute cycle of compressions. So next up, obviously, once you've started your compressions, you'll be looking at trying to maintain an airway. So the main goal with trying to maintain an airway is to provide ventilation and oxygenation to that patient. Obtaining an airway should be done as soon as viably possible. This can be done via ET tube, using a rigid unicatheter or a tracheostomy tube where available. It's really important to ensure you have a device which allows you to see the trachea to obtain the airway. So this can be a laryngoscope, an otoscope, an endoscope. You can even utilise a tongue depression, a torch where you can, but just trying to give yourself as much light to be able to see kind of where you're going with the ET tube or urinary catheter. You can kind of use the rigid catheter by, if you've got a breed such as kind of like your brachycephalic breeds, where it all swells up and goes really small, you can place the rigid urinary catheter down to get a source of airway and then kind of thread the ET tube over the top. So that kind of works quite well, but obviously it's case dependent on kind of how things go. Ideally, intubation kind of should be done in lateral recumbency or dorsal recumbency, depending on your patient, so that the chest compressions aren't interrupted. Once you have intubated your patient, one thing to remember, which a lot of people do forget, and it's easy to forget in the moment of doing them, is to make sure you securely tie the ET tube, just because the pressure of the compressions can sometimes dislodge the tube and kind of fire it back out. So it's really important to make sure you've got it kind of tied in and secured in place. Once you have kind of got your airway tube kind of in place and you're happy, ventilation to the patient should then be delivered simultaneously to the chest compression. Obviously, if your patient is already under anaesthesia, they will already be intubated. So it's really important in that moment to make sure your anaesthetic agent is turned off as soon as you recognise that they've gone into CPA. Ventilation, so this is your IPPV. This can be provided with an ambu bag connected to an oxygen source, or via a rebreathing bag connected to obviously an anaesthetic circuit. So it can be done either way, depending what you've got available to you at the time. By providing kind of the 2-minute cycles of chest compressions and breaths, this is you providing basic life support to that patient. Whilst doing your IPP, ventilation is kind of recommended by the recovery guidelines, that it shouldn't be, you should kind of administer a tidal volume of 10 mils per kilo, and it should be about a 1 second inspiratory time during the CPR. If you are unable to kind of intubate a patient, you can do kind of provision rescue breaths where feasible and safe to do so. This can be done during the pauses in chest compressions. They usually recommend kind of a compression and ventilation ratio of about 30 chest compressions to 2 breaths in those non-intubated patients undergoing CPR. It is important to remember that in those kind of patients undergoing CPR that do pose a kind of a risk to the rescuer, so those with kind of potential for zoonotic diseases or narcotic exposure, where you've not got access to kind of a face mask or intubation and things like that, in those instances, it's recommended the provision of rescue breaths via mouth to nose, or mouth to snout even, rather than kind of mouth to mouth, really, essentially. Obviously, if the patient doesn't, if it is kind of if they do pose a risk to the patient, where you've not got a face mask and you can't do mouth to snout, or you can't kind of provide their breaths, it is recommended to do chest compression CPR only where you are unable to kind of provide those breaths. With providing obviously the breaths, you're really looking at the ensuring that it's kind of effective breaths and things like that. So undergoing CPR, it's important that you kind of have a CO2 detection device in place. So more often than not, this is our capnography. and you would be, sorry, let me just mute that. So with obviously monitoring your kind of breaths and airway and making sure you're getting adequate ventilation and oxygenation to your patient, you would want a capnography in place, and you'd be looking at about an ET-CO2 above 12 mmHg, which with this, that would indicate proper ET tube placement. Anything below 12, it's kind of recommended to try and take another look at your tube, confirm that your tube is in place, just because obviously if you're getting that low of a reading whilst doing good ventilation, it just could indicate that your tube's not quite in the right place. So it's really handy to have a CO2 detection device in place to kind of be able to monitor those patients and kind of give further indication. Capnography is also a really good indicator of kind of chest compression efficiency, and can be one of the earliest indicators of ROSC as well, just because effective chest compressions does result in an increased pulmonary blood flow, which in turn improves alveolar gas exchange. So it has been seen that ET-CO2 values greater than 15 mmHg has been associated with an increased rate of ROSC. So you're kind of looking at with your capnography. If it's below 12, obviously just check your tube, check it's in place, check it's not become dislodged or anything like that. And if you're getting values above 15, these are kind of associated with effective compressions. So IV access, obviously once you've got your chest compressions underway and you've maintained your airway and you've got your IPPV going, you would be then kind of looking at IV access if it's not already in place. Different IV access points you can go for are, so you've got the cephalic, saphenous, medial saphenous, the ear, the femoral, sublingual, which is what the picture is of on the screen. That's what one of our nurses managed to do while they're here. Intraosseous, but this with the intraosseous, you need to make sure obviously that's a sterile procedure. So you generally might find you might not do that unless you're in some sort of kind of orthopedic procedure or it's absolutely necessary. You could go intratracheal or with a central line. So with just going back, sorry, to your intratracheal is obviously that's a very uncommon kind of use method, and this does obviously involve administrating the drug down the ET tube. So it would be important to make sure your kind of ET tube is in place correctly before administrating drugs down it. You generally, obviously this is done as a last resort, but you kind of put the drug down and then you'd be flushing that down with kind of 5 to 10 mils of sterile water to ensure the drug is kind of reaching those pulmonary tissues and just doesn't remain sat within the ET tube. Sterile water generally utilised with those cases just because it is absorbed better than saline, but saline can be used if it's kind of more easily accessible. With your intraosseous access, common sites for that generally include kind of the femoral head, the humeral head, and anything that can be given IV can generally be given at the same dose intraosseous, but obviously your vets will be kind of giving you doses in terms of giving drugs and things like that. With your drugs as well, obviously there's been within the last recover guidelines changes. They have changed some of the guidelines, so they no longer recommend high dose adrenaline, and they now recommend, if atropine is being used, just to administer it once early on in the CPR effort, and then don't repeat it again after that one. So then we're going to kind of preparing. Obviously we can't always prepare for a CPR occasion, because we don't know when a patient is going to be going into CPA. But obviously, if you've kind of got facilities and things available, to try and make it as easy and more successful for yourselves as you can. Obviously, that's kind of the best we can do. So crash boxes. So I've inserted some pictures of what our crash boxes look like here. So within the box, you've generally got kind of your emergency drugs, so your adrenalines, atropines, things like that. Needles, syringes, IV equipment. You can get like kind of pre-drawn sterile flush as well, which are really handy to have in those emergency situations. You can also do, I know in our trolleys we have kind of like we've got needles and syringes we put together. Obviously we don't have the drugs drawn up in them, but they're kind of handy to just be able to grab a needle and syringe already put together and just be able to draw the drug straight up. Tracheostomy tubes and ET tubes. Just make sure you've got an array of different sizes, just to suit all kind of patient sizes. IV fluids, suction catheters, and ambi bags. So you can kind of see on the first picture on the left, we've got our ambi bags kind of hanged on the side of ours. And also making sure you've got an ECG monitor and capnograph where available, to kind of hook straight onto your patient once you start doing compressions and breaths. You can do, obviously, if you've not got the 2 big trolleys like we have, so obviously the first trolley is the one we've got in our ICU, and the second one is what we've got in our prep area. But you can just have just like a little emergency box like we've got for the CT. So this is literally just like a tiny little toolbox that's just got the essential smaller version essentially of the big trolley. So it's just kind of got those drugs, ECG pads, ties, needles, syringes, things like that. Obviously we can't fit every single size of ET tubes in those, but for us, obviously we have them in CT where generally the patient is already tubed anyway. But it's if you are somewhere where we think there is a risk of the patient crashing, maybe just have like a little pack next to them of ET tubes ready, and then you can just kind of grab one and go if needed. So yeah, it's really handy to have a crash box. It is important with those crash boxes that they are checked often. We generally check ours daily, just to make sure they're all filled, that there's nothing missing, because the last thing you want is kind of a patient crashing and you've not got the things that you need in that crash box. So just make sure it's checked at least daily, and then kind of re-topped up if it does get used and anything is used out of the box or trolley. Rigid urinary catheters can be utilised for suction catheters if required, and obviously you can utilise IPPV instead of an ambi bag if you've not got an ambi bag available. So yeah, so they're really handy little things to have, just to make sure you're kind of well equipped in case a CPA does happen. So during CPR, you're kind of going to need a few team members where you can during CPR. So kind of people that you're looking for, you're going to need a lead of your CPR. Generally, 9 times out of 10, this will be a vet. They'll be kind of leading the CPR and kind of making decisions on what to do next. You're going to have your compressions. So these are people doing your chest compressions. Ideally, if you can have 2, so you can do 2-minute rounds and then swap out, that'd be great. Or it might be that you're kind of swapping between if there's just you and the lead, you're kind of flipping between the 2 of you. You might have then another person doing IPPV, so obviously they're important for kind of providing that ventilation to the patient. Someone doing drugs, so you might have someone drawing up drugs, someone giving drugs, but it is really important with that to remember that these need to be given under veterinary direction. So if you are, for example, working nights, and it's just you, a nurse by yourself, if you do find you're in a position where a patient's going to CPA and you're doing CPR, you kind of need to, even if you just get your vet on loudspeaker, just so that they can give you kind of drug doses and things over the phone. It's important to remember that ensure the patient is kind of on the floor or on a tub table or just any hard surface really, as hard surfaces are the easiest place to do compressions, because you generally find that if they are on like a mattress, for example, you've got the resistance and the bounce of the mattress underneath you, whereas if they're on a hard surface, it kind of makes those chest compressions more effective. You obviously then need to make sure that your owner is up to date during CPR. So whether it's an inpatient, you need to be getting on the phone to that owner and kind of obviously make them aware of the situation and get a decision from them what they want to do, whether that's carry on or stop the CPR where it is. So you need to make sure that the owners are kept up to date during the CPR. You can then, obviously, if there's enough people around and your kind of main bases are covered, you can have someone to kind of scribe and record things. So this is getting someone to kind of write down what time CPR was started, how many rounds of chest compressions you've done, what drugs were given, doses, times. They can kind of try and pester someone to go and update the owner. So just having someone to kind of document everything down just to make sure that kind of nothing's forgotten and you kind of know where you are with what's been given and things like that. It's really beneficial to have someone like that, and they kind of shout at you when 2-minute rounds are up and things like that. So they can be really beneficial if obviously if you've got the staff to do them. Again, if you've got enough numbers to do this, you can have a runner, so someone to go. If you've run out of anything, for example, if you've used all the atropine, for example, and you crash trolley, they can run and grab you some more. They can go and run you a fresh, get you a fresh ET tubes or something like that. It's just handy to have someone to be able to just run and go and grab your things where needed, or if you need anything extra grabbing during the CPR. You can have, I know we've got some here, we don't, in all honesty, use them very often, but you can have lanyards, which are really good to kind of establish crash rolls. So you can have literally a lanyard that says compressors on it, another lanyard that says IPPV, another one that says drugs. And you can even have, if you've got a runner, you wouldn't have going around and putting lanyards on people so everyone knows what the other person is doing, and you know that you're kind of not short somewhere, you know that you've got someone doing compressions, you know who's doing IPVV, you know who's doing drugs, and then you kind of know that all your bases are covered. By having that as well, you kind of then know if you are working in a big practice or a big hospital, you kind of know that if you call a code, you kind of have everyone kind of swarming to you and running over. So it kind of helps by having the lanyards. They can, if they're coming out of that situation, they kind of know what area is kind of needing a person and what needs covering, whether you need an extra person helping with compressions or doing breaths or things like that. So there's quite a few different things to potentially look at whilst doing CPR. So good practice. So there's obviously lots of different things you can do to kind of make things easier and kind of help yourselves when it comes to having to do CPR. So you can have a drug chart for all patients, whether this is one that you, print off and kind of stick next to the kennel or stick with their hospital sheets, or even if you can just have a little section on your anaesthetic sheet or your hospital sheet just with the pre-worked out drug calculations. Even if it's something that's coming in that you don't think is going to possibly crash at all, just work them out and then you are prepared for all cases, because like we said before, you just never know when a patient's going to possibly go into CPA. So as long as you've got your back covered and got your emergency drugs worked out, then you know if it does happen even in a patient that you wouldn't expect it to, then you've kind of pre-worked out. Kind of touched on this before, kind of having an emergency pack prepared. You could do this so we generally do this for critical patients, or you can do this for patients that you think maybe suspicious they could crash, so something such as a brachycephalic, which is presents fine, but obviously they're brachycephalic. So within them emergency packs, we kind of literally just have a little kidney dish with a couple of tubes in, a tie, and a laryngoscope, just so then you can at least start compressions and get a tube in. So we just have all of them next to any patient that we think is critical or anything that we think could potentially crash. Code pinks. So we call these code pinks. I don't know if people have got other different names for them elsewhere, but code pinks are essentially like a simulation of a crash. So it's obviously not a real thing. We call our crashes here code reds. So we do a code pink, which is just like a practice run of a code red, where we'll set up like a fake scenario, we'll call a code pink, and just do like a practice run of that. By doing that, it's really good to kind of help make sure that everyone's up to date, knows how to respond to these situations, kind of knows what they do need to do, especially if you've got kind of an influx of new starters, or it's not something you do. That obviously, if you don't have patients crashing very often, it's a good thing to do, just to kind of refresh your memory, make sure you all know where things are if something does crash. So they're kind of good to do, just kind of do whether it's once every few weeks, couple of months, however you like to do it. Just kind of do like a practice run of what you would do in a crash, and then kind of everyone knows what they need to do, how they need to respond, how they can be like utilised in that situation. And it's really important to kind of utilise all your staff members within a crash situation, because you can make use of kind of your receptionists, your animal care assistants, whether it is they are kind of opening doors for you to be able to get to, whether they are writing things down and being your scribe, or being your runner. You can kind of utilise those non-clinical team members within that situation as well. So doing reflections of the crash situation and kind of team discussion post CPR as well is really beneficial. So you can kind of reflect on, obviously have a team discussion, make sure everyone's okay, if anyone needs any additional support, anything like that. Just make sure everyone is okay, whatever the outcome of the CPR, whether it be positive or negative. Just make sure that everyone's kind of okay. And the reflection of the crash situation as well can be beneficial to kind of know what I don't want to say what went well, but kind of what went well, what didn't go well, what needs to improve. So then if it happens again, do you need to add in, do you need to add things into your crash box? Do you need to add in any extra kind of things into your protocols to make sure that it runs as efficiently and effectively as possible? And then you can kind of put them steps into place for if it does happen again. Another thing to kind of bear in mind as well is, obviously, if your CPR is successful and you do get your patient back, providing kind of adequate analgesia for that patient. Obviously, they are going to be very, very sore post-chest compressions. So it is important to kind of have a chat with you there afterwards and see, kind of get that analgesic plan from them, and kind of make sure the patient is as comfortable as possible post CPR. The recovery, like I mentioned earlier, they do a really good CPD course online. I can't remember, but I think it's something like recover online, but it covers basic life support and advanced life support. So it's kind of like a certificate that you can do online, which is really, really good. And that kind of just gives a really good in-depth information about kind of CPR and kind of why we do it and how the body responds and things. So it's kind of worth doing if you've got, it's beneficial for everyone really, but it's kind of good to kind of cover all bases. The Recover do have a really good app as well that you can download on your phone, that if you are in the situation where you are having to provide CPR, you can kind of set the app going, and it almost has like a ticker that is the kind of the rate of what you need to provide chest compressions, if that makes sense. So it kind of will then shout when it's 2 minutes. It kind of has a ticker that goes at the rate of what you should give chest compressions, and also does like a deep breath on the app as to when you should be given a breath. So it's quite beneficial if you're not sure what rate you should be giving chest compressions or the kind of speed that you need to be going at, it could be quite a handy little thing to kind of set going once you start doing CPR. Prevention, so like we've kind of said previously, obviously we can't prevent CPA happening if it's going to happen, but we just need to be as prepared as possible. So it's just important to kind of always be prepared for the inevitable or the worst. Kind of if you're prepared for the worst case scenario, hopefully it won't happen. So just make sure you've kind of got that monitoring equipment available and working if you need it, so your capnography, your ECG. The three most common kind of arrest rhythms that we do see that are the asystole, the pulseless electrical activity, and the ventricular fibrillation, which are kind of attached pictures of the bottom, so you can kind of see what they look like. The asystole, so that indicates kind of complete stopping of electrical and mechanical heart activity. The pulseless electrical activity is cessation of mechanical heart activity but continuation of electrical heart activity. During pulseless electrical activity, so P, the electrical activity in the heart is sufficient to kind of generate electrical potentials that can be picked up by an ECG. However, there is very weak or absent kind of mechanical activity. So this just does mean that the heart fails to generate sufficient blood flow to produce kind of those palpable pulses. So although it is providing an ECG, it is by no means a sufficient heart beat or kind of anything good, basically. The ventricular fibrillation, so that kind of indicates uncoordinated mechanical heart activity. So the muscle cells in the ventricles basically have like a quivering mechanical activity. So that results in ineffective contractions and insufficient cardiac output. So kind of it's quite important to kind of know what your ECGs are and kind of what they're indicating in terms of your heart activity, basically. Like we said, obviously previously touched on, capnography is really useful and can be a really useful indicator of kind of your chest compression efficiency, and let you know if there's an indicator of the return of spontaneous circulation as well. So yeah, it's just really important with CPR to just try and be as prepared as you possibly can, just to try and cover all bases, even if it's something that's coming in just for like a generic spay that you think, oh, they'll be absolutely fine, it's a fit, healthy young dog. Just at least get your emergency drugs worked out, just in case anything was to happen. You can at least have covered, you kind of got your back covered a little bit, just in case the worst happens. But yeah, I think they're just some references that I kind of used for this PowerPoint. Like I said, there's some really good resources kind of online. The Recover CPR guidelines and things are really useful to kind of look at, and they've updated them all last year, so they're all kind of really up to date. But yeah, I think that's everything in my way. I'll turn off my stop sharing and all that. I don't know if anyone's put anything in the chat or not.
No, so that's all fab. Thank you very much, Lucy. There's no questions in the chat. Has anybody watching got any questions that they want to ask there at the end about anything in the presentation? No, that's fine. I mean, as I sort of said at the beginning, I know a few people joined throughout there, that there are a number of people that couldn't come to the presentation this evening, but will be receiving it as a recording of this presentation that Lucy's done. So we'll be sending those out. If anybody who's watching it back on the recording has any questions as well, or if someone just doesn't want to ask the questions that they've got now, they can drop it through on email to either myself or Lucy. So it's ellen.harrison@swiftreferrals.co.uk or lucy.booth@swiftreferrals.co.uk. And we'll be able to answer any other questions if you've got any at all. But otherwise, I think that's it for us this evening. We won't keep you much longer. That's fab. Well, thank you all for attending. Those of you that have attended, I'll get a CPD certificate as well, and just let me know if you want it on a recording, and I'll email it out. So anybody else in your practice can view it as well. All right. Take care, everybody. Thank you.
Thanks.